From Microbe TV, this is Infectious Disease Puscast, episode 46, recorded on January 17th, 2024. Hello, everyone. I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. So for those who are listening and not watching, you can't see the beautiful sunset that is behind Daniel that I'm very envious of right now.
I had an even better view of it, but then there's like these glare from the lights coming down, so that's all you get. But yeah, I'm about 20 miles north of Venezuela. So, beautiful, warm in the 80s, the wind's blowing 20s every day. Quite the opposite of the freezing sleet that I left behind in New York.
Yeah. Well, Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
We shall, and we will start with viral. And I want to remind everyone to continue to listen to TWIV, This Week in Virology, both the weekly clinical updates and the deep dives. And let me start with an article, and I love articles that highlight the intersection between infectious disease and climate change. I was recently commenting on how some inland homes would become more valuable when climate change arrives. And my sister-in-law, Genevieve, asked, what do you mean by when? Yes, climate change is already here, as we read in the major article comparing the performance of 3 models incorporating weather data to forecast dengue epidemics in Reunion Island 2018 through 2019, and the editorial elucidating the impacts of climate on dengue transmission through mathematical models, new evidence from a recent outbreak on the island of Reunion, both published in JID. See how I slipped in 2 there, Sara? It's like cheating. Let us walk through the papers. Now, the seroprevalence of dengue virus among blood donors in Reunion Island was estimated at 3.1% in 2008, and only a few hundred dengue fever cases were reported between 2008 and 2018. However, this assumption changed in May 2019 when new serological data from studies performed by the French Blood Bank using samples collected in August 2013 became available. These studies estimated the seroprevalence among blood donors at 24.1% in 2013. So in early 2018, in the French overseas island territory of Réunion, surveillance systems detected a rise in dengue cases, which would turn out to be the first of 4 successive mid-year seasonal waves of increasing intensity. This represented a unique opportunity and resource for a disease modeling perspective, a temporarily and geographically contained dengue virus outbreak taking place within a relatively stable, closed, and well-surveilled population. The authors fitted a susceptible infectious recovered model, a SEER model, to this incident case data and included a scaling factor that they allowed to vary as a function of prevailing weather conditions. The investigators compared 3 mathematical models to forecast the dengue virus epidemic in Reunion Island 2018 through 2019 and strengthened the risk assessments of Santé Publique France. Their forecasts accurately anticipated the observed epidemic trajectory and were used at a national and local level to inform planning and to optimize resource allocation. The biggest connection seemed to be between temperature and the dominant vector Aedes aegypti. All right, I'm going to throw another one in here. The article, infants receiving a single dose of nirsevimab to prevent RSV do not have evidence of enhanced disease in their second RSV season, recently published in JPIDS. And I think really appropriate right after a study on dengue, where we learned about this phenomenon, many of us. Here, children from the phase 3 MELODY trial, it's over 3,012, were followed through their second RSV season. This is important because in the 1960s, enhanced disease severity was observed following administration of a formalin inactivated RSV vaccine. A concern is that binding of non-neutralizing antibodies or antibodies binding to viral antigens at sub-neutralizing concentrations without adequately blocking or clearing infection has the potential to lead to the promotion of antibody-dependent enhancement of infection. Here, we are seeing no concerns for this ADE issue, antibody-dependent enhancement.
And I pulled one viral paper from OFID, Patient Perspectives on Solid Organ Transplantation from Donors with Hepatitis C viremia to Recipients without Hepatitis C viremia. This is actually a really nice study looking at something a little different than we talk about, but the psychosocial impact and experiences of 24 Hep C donor positive, recipient negative patients. This was based on some in-depth interviews sort of looking at their experiences receiving these organs outside of a clinical trial. So the interviewees, the transplant recipients, described being motivated by the trial results of successful hepatitis C donor positive, recipient negative transplants, and having that explanation provided to them that this is an effective and safe option. The other reasons motivating them to accept these organs were the perceived survival benefits and reduced wait time. And so many particularly noted that expedient pathway as a reason to accept. And then many of the interviewees sort of expressed their perception that, a hepatitis C donor positive recipient organ transplant was sort of a no question option, meaning they saw the alternative to not accepting as potential death. And so the author sort of summarized that in their thematic analysis with this better than dying quotation. As far as concerns, some of the interviewees mentioned costs, but it really did not outweigh the perceived benefits. And most of them accessed the hepatitis C treatment within a month, although a few mentioned some delays in insurance coverage, which ultimately slightly delayed when they started treatment. And then most did not express experiencing stigma, although they did, it sounded like, often sort of selectively decide who to share that information with as far as relating to the hepatitis C organ. And then a few of them did have family members who had concerns about acquiring hepatitis C. So just like a different perspective of what the patients are thinking as they receive these transplants.
Yeah, really troubling about the stigma concerns. So just great to have that information out there. All right. The potentially practice-changing, impacting article here in the bacterial section. So be sure to listen to This Week in Microbiology. Turn this around so I'm not blasting my blue microphone light at everyone who's trying to watch. The article, Oral Beta-lactams, Fluoroquinolones, or Trimethoprim sulfamethoxazole for definitive treatment of uncomplicated E. coli or Klebsiella species bacteremia from a urinary source was recently published in Open Forum Infectious Disease. So these results are from a multi-center observational cohort study that compared effectiveness of fluoroquinolones, TMP sulfa, or those beta-lactams, high bioavailability beta-lactams, for gram-negative bloodstream infection oral step-down therapy. So here they looked at 648 adults treated between 1/2016 and December 2022 for uncomplicated E. coli or Klebsiella species bacteremia of urinary tract origin who transitioned to an oral regimen after less than or equal to 4 days of effective intravenous antibiotics. And that seems pretty standard. They report that compared to fluoroquinolones, TMP sulfa had similar effectiveness, it's adjusted hazard ratio 0.91, and the high bioavailability beta-lactams had a higher risk of recurrence, adjusted hazard ratio of 2.2. Although I will point out that difference in this group of 648 was not statistically significant. So we're talking about a trend. Most 70% of the high bioavailability beta-lactams were not optimally dosed for bacteremia. Total antibiotic duration of less than or equal to 8 days was associated with higher recurrence in select patients with risk factors for failure. So let me put this in context. Prior to the study, several retrospective studies that they cite have shown no difference between the fluoroquinolones and beta-lactams. But then there was a meta-analysis and some other studies suggesting higher rates of recurrent infection with the beta-lactams. Interesting analysis on duration and C. diff rates that seem a bit at odds compared to other studies. They make the comment that perhaps in the real world, there are differences not seen in RCTs.
There has been an ongoing shortage of erythromycin ointment, which is the recommended choice to prevent ophthalmia neonatorum caused by Neisseria gonorrhea. The AAP, American Academy of Pediatrics, did release some guidance on what people should do and use during the shortage. So I just thought I would let people know in case you get called. Here's what they suggest. For a birthing parent who is at risk for exposure to Neisseria gonorrhea or who had no prenatal care, they should be tested with a NAT test in the immediate peripartum setting. If positive for gonorrheal infection, or if the test is pending at discharge and you are concerned about their ability to follow up, the neonate would ideally receive 25 to 50 mg per kg of ceftriaxone, IV or IM. And if ceftriaxone is not available, or you can't use, you could use single dose of ceftazidime or cefepime. And I thought I would just read directly from what they listed as, quote, at risk. So they listed women under the age of 25 years old and those 25 or older who have a new partner, more than one sex partner, a sex partner with concurrent partners, or a sex partner who has a sexually transmitted infection or lives in a community with high rates of gonorrhea. There's a little bit more, sorry. Practice inconsistent condom use when not in a mutually monogamous relationship, have a previous or coexisting STI, have a history of exchanging sex for money or drugs, or have a history of incarceration.
All right, the article Discontinuation of Contact Precautions for Methicillin-Resistant Staphylococcus aureus in a Pediatric Healthcare System was recently published in JPITS. Now, many hospitals caring for adult patients have discontinued the requirement for contact precautions for patients with MRSA, infection, or colonization without reported negative effects. But what about pediatric facilities? So CP for MRSA was discontinued, that's contact precautions, was discontinued in all locations except the neonatal intensive care unit at a 3-hospital pediatric healthcare system in September 2019. All hospitalized patients underwent surveillance for lab ID healthcare facility onset MRSA infections. They found that discontinuation of contact precautions for pediatric patients with MRSA was not associated with increased MRSA infection over 4 years.
I love it. This next one I pulled from the Lancet ID, oral linezolid compared with benzathine penicillin G for treatment of early syphilis in adults. The TREP-AB, capital AB study in Spain, a prospective open-label, non-inferiority, randomized controlled trial. So as the title tells you, this is multi-center, you heard the rest, open-label, non-inferiority, RCT, to look at the efficacy of linezolid for treating early syphilis compared to penicillin G. This is from Spain. Patients received either oral linezolid 600 milligrams once a day for 5 days or IM benzathine penicillin G 2.4 million international units. They were assessed once weekly until week 6 after treatment, and then at week 12, 24, and 48. Non-treponemal antibody testing was sent on weeks 12, 24, and 48. So the primary endpoint was treatment response. So that was a composite endpoint of clinical response, serological response, and absence of relapse. So for clinical cure, that meant healing of primary syphilis lesions within 2 weeks and secondary syphilis lesions within 6 weeks. And then for latent, it's not really assessed. There are no visible lesions. For serologic cure, it's a 4-fold decline in RPR or seroreversion at the time points of 12, 24, and 48 weeks. And then for clinical recurrences, they investigated relapse versus reinfection with multi-locus sequence typing and whole genome sequencing. So there were 62 patients, 29 were assigned to linezolid, and 30 to penicillin. In the per protocol population, after 48 weeks of follow-up, 19 or 70% of the linezolid group responded to treatment versus 28 or 100% of the penicillin group. So that did not meet the non-inferiority criteria. There were similar drug-related adverse events. And so this had been stopped early because of this difference in the linezolid group. And the take home was that the efficacy of linezolid was not non-inferior to penicillin for early syphilis. But I think obviously this is notable because the daily dose of 600 milligrams, we obviously want more trials investigating other agents for syphilis. And of course, it's a little bit of a bummer. It wasn't at BID dosing, but they selected it as a balance, it sounds like, between efficacy and convenience. So linezolid has been used once daily for multi-drug resistant TB, and there is some simulation data that the authors used, and the frequency was based on the concept of cure for infection being achieved if the drug treponemasidal concentration was maintained over 5 to 7 days. It was sort of a balance of what was done and some prior original experiences. Some of the next steps would potentially be not only considering BID dosing, but whether or not a longer course is appropriate. There's no way to sort of tell why this didn't work for these patients. So I suspect if people are stuck, they're probably reaching for doxycycline if they feel like they can't use penicillin. But hopefully we'll get more information. It's still a neat study and I think is a good one for people to take a look at.
All right. The article, Model-Informed Precision Dosing Improves Outcomes in Patients Receiving Vancomycin for Gram-Positive Infections, recently published in OFID. So here we go. Consensus guidelines for dosing and monitoring vancomycin recommend collection of 2 serum concentrations to estimate an area under the curve, MIC, AUC/MIC, use of Bayesian software for AUC estimation, and model-informed precision dosing enables pre-steady state therapeutic drug monitoring using a single serum concentration. So let's compare those two approaches. Couple different serum concentrations or just one. Adult patients with culture-proven gram-positive infections treated with vancomycin for greater than or equal to 72 hours received either the trough-guided or AUC-guided therapy, which included in this retrospective study AUC-guided therapy provided using the single concentration monitoring or the multiple treatment success, vancomycin-associated acute kidney injury and inpatient mortality were compared using a desirability of outcome ranking, a DOOR analysis. The most desirable outcome was survival with no vancomycin-associated acute kidney injury. And the least desirable outcome was death. So glad they pointed that out. The study population, N equals 300, was comprised of an equal number of patients receiving AUC-guided or trough-guided therapy. More patients experienced the most desirable outcome in the AUC-guided group compared to the trough-guided group. 58.7 versus 46.7. Rates of acute kidney injury were lower with AUC, 21.3% versus 32%, and median hospital length of stay was shorter among patients receiving AUC-guided therapy, 10 days versus 12. So I think a couple exciting things here. One, just reinforcing that calling that pharmacist, having them help you with the AUC MIC instead of trough guided, and also some interesting information if you dig a bit deeper into single versus double measurements.
We haven't talked about vancomycin in a couple episodes.
Imagine that.
This next one I have is from CID. The expert MTB-RIF cycle threshold value predicts M. tuberculosis transmission to close contacts in a Brazilian prospective multicenter cohort. So this prospective multicenter Brazilian study looked at the association of the expert MTB-RIF CT values and transmission to close contacts of patients with culture-confirmed pulmonary TB. So this is from the Report-Brazil Consortium or cohort. So as a reminder, the CT value is inversely related to the bacillary load. So the lower number of cycles that you need to find that DNA in the sample suggests a greater burden of bacteria there. So there were 1,055 close contacts of 382 pulmonary TB cases that were included. 333 or 32% of the contacts had a quantiferon that was positive at baseline, and then an additional 91 contacts subsequently tested positive at 6 months. And there were close contacts of all ages, including children under the age of 15. And so the key finding was that there were lower median CT values of index pulmonary TB cases that correlated with quantiferon positivity in the contacts, both at baseline and then conversion by 6 months. And adjusted logistic regression demonstrated that the reduced CT values from the index cases were independently associated with quantiferon conversion. So a 1 unit decrease in the mean CT value across all the probes was associated with a 61% increase in the odds of conversion among their contacts. So this connects the expert MTB-RIF assay to bacillary load and risk of transmission, which is super interesting. So in the future, they may be able to look at different cutoffs. This study specifically used 0.35 international units per ml for positivity. So I thought this was just really cool and interesting to think about how this could potentially be used by TB control programs in the future. Would it be able to help focus which contacts may be the priority where you maybe don't have as much support? I know there's a ton of work that has to happen between this type of study and in practice, but it's a really neat concept.
Yeah, no, I love this stuff. I mean, hopefully people started thinking about this with all the attention paid during COVID, like, hey, all the other PCR tests that have CT values, what can we do with that information? One, please share it with us. And then maybe after a while, we'll start to see these patterns like this. All right. The article, Efficacy and Safety of a Structured De-escalation from anti-pseudomonal beta-lactams in bloodstream infections due to Enterobacteriales, simplify. An open-label, multi-center randomized trial published in the Lancet Infectious Diseases. So these are the results of an open-label, pragmatic, randomized trial performed in 21 Spanish hospitals. Patients with bacteremia caused by Enterobacteriales susceptible to one of the de-escalation options and treated empirically with an anti-pseudomonal beta-lactam were eligible. Patients were randomly assigned 1-to-1, stratified by urinary source to de-escalate to ampicillin, TMP sulfa, thus urinary tract infections only, cefuroxime, cefotaxime, or ceftriaxone, amoxiclav, cipro, or ertapenem in that order according to susceptibility, or to continue with the empiric anti-pseudomonal beta-lactam. That's the control group. It turns out that what we have been taught in this case is actually true. De-escalation from an anti-pseudomonal beta-lactam with Enterobacteriales bacteremia was non-inferior to continuing that empiric anti-pseudomonal drug.
Speaking of gram-negatives, my next article is from CID, Oral Antibiotics for Treatment of Gram-Negative Bacteremia and Solid Organ Transplant Recipients, a Propensity Score Weighted Retrospective Observational Study. So I'm sure really most of the podcast listeners already know that, but there are many studies about switching to oral antibiotics for gram-negative bloodstream infection, but there isn't a ton of focused data on immunocompromised host and solid organ transplant recipients, because typically they would use those immunocompromising conditions as an exclusion. So this study took a look at 162 bacteremia events from 147 solid organ transplant recipients in Boston from 2016 to 2021. So they had uncomplicated gram-negative bacteremia. The oral antimicrobials that they used for this study, or the focus of the quote bioavailable ones, is fluoroquinolones, trimethoprim sulfa, metronidazole, cefuroxime, cefpodoxime, and amoxiclav. So they compared the outcomes of those who were transitioned to oral versus those who continued IV. So there were 120 bacteremia events and 107 patients who were treated with oral step down, and 42 bacteremias and those treated with IV only. In those that were in the oral group, the median duration of IV antibiotics prior to switching to PO was 4 days. There was about 10% of the group who received over a week of IV therapy, and the median duration of total therapy was 15 days. So there was no difference in mortality, bacteremia recurrence, or reinitiation of IV therapy between the oral and IV groups, but the IV treatment group did have some more complications. So no patients died in either group within 30 days. 2% of those in the oral therapy group versus 5% in the IV therapy group had recurrence, so the p-value on that was 0.27. And in the oral group, 2% developed C. diff infection and 3% had other treatment-related adverse effects. And you can compare that to 12% and 10% in those of the IV therapy group. So the p-values on those respectively were 0.015 and 0.002. I think another important thing to pull out is that 55% of the patients in the IV group required placement of a new tunneled central venous catheter. And, the authors mentioned that maybe this is a reflection of how, often we can't use PICCs, or it's sort of preferred to avoid the PICC in patients who are recipients of kidney transplants. So I like the take-home message of this. You could say, oh, it's a retrospective study. The docs probably chose healthier patients for who got oral therapy, but they did try to account for this in their model. And honestly, we operate on extrapolating data and studies of similar quality to make plenty of decisions in ID. So I hope this gives people more confidence to consider use of oral step-down antibiotics, even for some of our transplant patients, not just our healthier immunocompetent patients.
And I'm thinking this could use a prospective randomized controlled trial, Sara.
Yeah.
All right. Let's move into fungal. When is The Last of Us going to have its second season? Do you know, Sara? Is anyone following that?
I think they're recording. I thought they were recording already. Maybe after award season. I don't know.
Okay. All right. So fungal, the article Dematiaceous fungal keratitis with tentacles mimicking Pythium keratitis was recently published in JAMA Ophthalmology. And I think I put this in mainly just for the pictures. Here we have a 60-year-old man presented with a corneal infiltrate. And I just think, to raise awareness, but also pretty interesting stuff. I think people should take a look at the striking photos.
Yeah. And I just have a update. This publication was an OFID, but we've talked about the outbreak a couple times. Outbreak of Fusarium solani meningitis in immunocompetent persons associated with neuraxial blockade in Durango, Mexico, 2022 to 2023. So this is another update on this U.S.-Mexico binational outbreak. A total of 1,800 persons were exposed to epidural anesthesia and identified. Of those, 80 developed meningitis. They eventually ID'd Fusarium solani in 3 brain biopsies, which did show susceptibility to voriconazole and amphotericin. And then after they had a Fusarium solani PCR and implemented that, 57 patients with meningitis were PCR screened, and 31 or 39% of them had a positive result. I think the most like striking part of this is the case fatality rate was 51%, so 41 patients. And to also point out that these were almost all exclusively young 30-ish year old women who had received some sort of procedure, but 3/4 of those were C-sections. So just it's very sad. So enormous amount of work for everyone who was involved in the outbreak. So for those who've been sort of following along, it's another update on what became of that outbreak.
Yeah, really tragic. I mean, a 51% case fatality rate, looking at, women in their 30s. The only exposure may be a C-section. All right. Well, the article, Verification Analytics Sensitivity, Cost Effectiveness, and Comparison of 4 Candida auris Screening Methods, was published in Open Forum Infectious Disease. What Puscast would be complete without a Candida auris paper? In this verification study, the investigators compared and contrasted the performance characteristics of a chromogenic agar culture, direct PCR, and broth enrichment, followed by either culture or PCR for the detection of Candida auris colonization. They found that culture and PCR both offered excellent performance, with broth enrichment offering little performance advantage given its cost. I was hoping for cool pictures of the cultures, but no. All right, I'm going to move us right into Parasitic. Be sure to listen to This Week in Parasitism. It's now bi-monthly, every 2 weeks, so getting a little bit more. One day it might be this week. The article, Tefenaquine Atovaquone Combination Achieves Radical Cure and Confers Sterile Immunity in Experimental Models of Human Babesiosis, published in JID. So we've discussed previously that we seem to be having a harder time clearing parasitemia with this infection in our area, and we are reading about the emergence of resistance to current treatments. In this article, the investigators demonstrate that the 8-aminoquinolone antimalarial drug tefenaquine inhibits the growth of different Babesia species in vitro, is highly effective against Babesia microti and Babesia duncani in mice, and protects animals from lethal infection caused by atovaquone-sensitive and resistant B. duncani strains. They go on to show that a combination of tefenaquine and atovaquone achieves cure and no recrudescence in models of human babesiosis. In addition, elimination of Babesia duncani infection in animals following drug treatment also confers immunity to subsequent challenge. The data suggests superior efficacy of tefenaquine plus atovaquone combination over current therapies for the treatment of human babesiosis and highlight its potential in providing protective immunity against Babesia following Babesia clearance. Now, I'm also going to leave in a link to the paper Relapsing Babesiosis with Molecular Evidence of Resistance to Certain Antimicrobials Commonly Used to Treat Babesia microti Infections, published this past January in Open Forum Infectious Disease, where they review this growing problem and discuss the molecular evidence of genetic resistance to certain antimicrobials commonly used to treat B. microti infections based on an evaluation of 9 patients with relapsing infection.
And I will finish this out with our miscellaneous section. The first one I have is Paying for Parenthood, Understanding Parental Leave Policies and ID Fellowship, published in OFID. This study investigated how infectious disease fellowship program directors interpret leave policies set by the American Board of Internal Medicine and found that nearly 70% of respondents incorrectly identified the limits that were permitted for trainees. So a majority extending training when a competent fellow was still actually within their allowed duration of leave. And so they were sort of applying policies incorrectly when given example scenarios. So this obviously affects a trainee's well-being. I will say as someone who's in training for a long time, but ultimately it also is a very significant long-term financial and professional cost if someone has an unnecessary extension in their therapy, when they get a job, when they can sit for a board, and so on. So really great work by those authors. And then the last thing that I had was to sort of point people to this resource. I'm not going to summarize everything in it, but what's hot this year in ID clinical science. is a summary of topics in CID, but basically topics that were highlighted in the What's Hot in ID Clinical Science at ID Week 2023. So they, walk through their thought process in the papers or the studies that they included. So I just want to point out that I think Daniel and I did pretty good. We talked about majority of what was mentioned in there, maybe not all of them, but so I encourage you to keep listening and send us your recommendations if you think we've missed things. And that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. And we love to get your questions, comments, and paper suggestions. And so if you feel like we left out anything that's hot, just send them to puscast@microbe.tv. If you like what we do, or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or now, particularly during the month of January, when we are doubling donations up to a total of $20,000 for Microbe TV, go to parasiteswithoutborders.com, click on the donate button.
I'm Sara Dong. You can find me at swindong at Federal Podcast or at federalpodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, end dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.